Hi, I'm Todd Valines, and I want to welcome each of you to our SCCT webinar. This is an industry-sponsored webinar, and I'm the Chief Medical Officer for Elucid. We are excited to bring to you part two. This is the second in a two-part series. The title is Optimizing Coronary CTA, where today we're going to talk about reimbursement, reporting of CTA findings, and plaque. I'm very pleased to have with us today an esteemed panel of speakers and panelists, and I want to thank you all for taking the time out of your very busy schedules to be with us today. I'm going to introduce our speakers and the order that they will be presenting, and our first speaker is Dr. Ahmad Slim. Dr. Slim is an associate professor of medicine at the University of Washington and the regional chief medical officer for Pulse Heart Institute in Tacoma, Washington. And as you are probably aware, he is very active in the field of the finances and reimbursement for CT. He has served as the advisor to the AMA CPT panel on behalf of the Society of Cardiovascular CT. He is a member of the American College of Cardiology Coding Task Force, a member of the SCCT Advocacy Committee, and a member of the SCCT Board of Directors. And Dr. Slim will be speaking today on the finances of coronary CT in 2023 and going into 2024. I'm also joined, our second speaker today, by Dr. Mark Rabat. Dr. Rabat is a professor of medicine and professor of radiology, as well as the director of cardiac CT and the director of the structural heart disease interventional imaging program in the Division of Cardiology at Loyola University Medical Center. Mark has been a leader in the field, has published over 250 manuscripts, as have all of our speakers, and will be speaking us today on when to utilize quantitative coronary plaque analysis and FFRct in guiding patient care. And then finally, our third speaker is Dr. Brian Gashadra. Dr. Gashadra is the associate chair of Operations Analytics in the Division of Radiology at Massachusetts General Hospital. He's also the academic director of cardiovascular imaging and an associate professor of radiology at Harvard Medical School. And as all of you are probably aware, is the immediate past president of the Society of Cardiovascular CT. He's published also loads of papers. And what's important about all of our speakers today is they are busy at the bedside practicing cardiovascular CT. And so they live and breathe this day in and day out. I'm going to be the moderator today. I am the chief medical officer, as I mentioned, of Elucid. I'm also a professor of medicine at the University of Virginia and a past president of the Society of Cardiovascular CT. I want to finally encourage all of you to make this interactive. And so there is a question and answer panel. Please submit your questions. We have built into the agenda today, in addition to the three speakers, plenty of time for question and answer. We're going to have a panel of the speakers and myself to try to answer your questions as they come. And please send your questions in. We want to hear from you. We want, ask us the hard questions. And so with that introduction, I'm going to turn it over to our first speaker, Dr. Ahmad Slim, who again will be speaking about the finances of coronary CTA in 2023. Thank you, Ahmad.
Thank you, Todd. Thank you all for having us today. As we head into 2024, we've had a couple of discussions at SCCT annual meetings about the finances of coronary CT and understanding the billing and the reimbursement components. So the goal of today is to really try to break it down as much as possible into the basics of how do we bill, how codes are generated, and the finances that comes with all imaging, not just cardiac CT. Next slide is just highlighting some of my disclosures. As Todd highlighted, I sit on the AMA CPT panel as an advisor on behalf of SCCT and the ACC Coding Task Force. When we talk about policies, policies are guidelines that covers reimbursement. All payers have policies, and these are national policies. And when these policies are generated, there's a lot of balancing that leads to these policies. We assume that it's based primarily on guidelines and randomized clinical trials, but it's really that the guidelines are the pivoting point, balancing out the consumer, long-term benefits, short-term benefits, coverage, and payments. So there are a lot of components that goes into generating a healthcare policy. We've all interchangeably use the word policy, coverage, and reimbursement when we're going through residency and fellowship and training, when they are not interchangeable. And it's just simply because we never had the basic education that goes over these topics to make us understand how it works. Healthcare policy, as I highlighted earlier, is a guideline generated by a payer. That's a nationwide guideline that covers potential coverage of a technology. Just because you have a policy that's favorable does not mean that when it comes for the area that you're in, the coverage will be favorable. Each region in the United States is divided into segments. So when we look at the United States map, there's a Pacific Northwest, Northeast, and these are divided into regions. And these regions are managed by a healthcare managed care system that implements the policies. And this is where the coverage is determined. And that's why you hear the word local coverage determination. Just because you have a favorable policy, you can still have an unfavorable local coverage determination. So, and that's the part where you become active. This is the negotiation that happens between the system and the payers to have a favorable coverage and expand on the indications by which the technology is paid. Here's another layer. Coverage does not equals reimbursement. Reimbursement is the piece that we're interested in, right? We do the work, we follow the guidelines, we take care of the patient, we submit the claim, we expect to be reimbursed. And just because you have a policy that's favorable, coverage that's favorable, does not mean that you will get reimbursed, because there are layers within reimbursement that highlights how you get paid. Some of it might require that you use the right ICD-10, appropriate use criteria built into your technical electronic medical records, so on and so forth. So unfortunately, there are hurdles to reimbursement. So that's why I say they're not interchangeable, policy, coverage, and reimbursement, and you have to understand the difference between them. Our ultimate goal is for them to hopefully be interchangeable, but as of now, they are not. So a perfect example, as you all know, coronary CT, stress nuclear, and stress echo. We have a favorable guideline towards cardiac CT with more indications than any of the above. Yet, when you look at the reimbursement piece and payment for coronary CT is set much lower than the other technologies. And on top of it, there are hurdles to payment, and it does not cover the cost of the work that's being done. So the question is, if we have favorable policies and guidelines, if we have high coverage, why is reimbursement low, and why is it not cover our costs? Multiple layers are involved. When you look at coronary CT, we do have a lot more layers than other coronary CT, other CTs. But yet, when we look at the payment system, especially under the OPPS, which I'll cover later, it falls under all CTs. So it gets bundled with all CTs when it does take a lot more layers to coronary CT to administer the test. You need modern CT scanners, EKG gating, medications, nursing support, 3D processing system, further analysis. So there are significant amount of work that is not accounted for because coronary CT falls under the same APC as other modalities, and it gets average and it loses value in the process. So we're going to go a little bit to the basics. How is a code generated? We all use codes when we order a test. We just go into our electronic medical record, type coronary CT, and then we order it and move on. However, the CT itself is linked to a CPT code. And that CPT code that we use is called Category 1 code. A CPT is current procedural terminology. We've always assumed, and I'm one of these folks in residency, that these are handed over from the cloud and just determined by policies and payers, and we just have to live with it. And the truth couldn't be farther from that description. CPT codes are generated by the American Medical Association, by a panel of peers. A new technology comes into the world, and it has to go through 3 steps before it solidifies into a Category 1 that we use. Initially, it hasn't been FDA approved. It's still in the research world, or we're still trying to track it. In that part of it, it falls under something called HCPCS, or Healthcare Common Procedure Coding System. This is the system that we use to account for our perishables. Perfect example would be Lexi or adenosine. They are pass-through cost, and because they are pass-through cost, we use the hex specs. There is no associated work that goes with a provider. So a new technology initially will fall under the hex specs code, just for initial tracking purpose. Once that technology gets FDA approval, and it has a little bit of an increased utility, then it goes to a Category 3 code. And a Category 3 code is a temporary code that is divided into mostly two components: a professional component, and that's the workload of the provider, and a technical component. And this is for tracking purposes, because we still have not assigned RVU value to a Category 3 code. We assign it only to Category 1. So this would allow us to build a database. Off of that database, it goes back to the AMA panel, and it generates a Category 1 code that we later use, and is divided into professional or technical component. Technical to cover the cost of doing the test, and a professional for the provider component. So this is a rough idea of the process itself, which we'll go into it in details. So a perfect example of a current T code is the Plaque code. And a Plaque code, like I said earlier, usually our Category 1 codes are divided into technical and a professional. But when you're doing a Category 3 code, you can structure it in any way that you want, because it's not intended for payment, it's intended for tracking. But yet, if we don't use it, we will never be able to cross into Category 1 because we need that data. So this is a perfect example where it's divided into three components. A professional component, you always need one to be able to generate a code. And that accounts for the provider time. And two technical components, one for the site itself that prepares the studies to be sent, and one for the company that processes AI augmented work. And that would allow us to track it as we progress towards a Category 1. So some of the common questions is, can you get paid for a T code? And the answer is yes. We want you to use T codes. We don't want you to say, they don't pay, therefore we're not going to use them. Because if you don't use them, we'll never be able to cross into Category 1 where you're very well reimbursed for your work. And this is when you meet with the payers and we determine the local coverage determination. It goes back to the initial slide. You have a policy, you have guideline that supports the use, it's FDA approved. You meet with the payer and you work with them on local coverage determination. Then the next question is, well, how do we prepare for that payer meeting? You really don't want to go in with a payer or a MAC meeting to ask for increase in payment, and in the process not be prepared. So you want to make sure that you have a zip drive with abundant data and publications. And most of the time, the society can help you with that. If you reach out to the society, we have resources, and we can help you create that zip drive ready articles, guidelines, randomized clinical trials that you can share with the payer prior to your meeting. Write a brief summary and answer any questions they have before the meeting. And this is when you collaborate again with the society, and we've helped multiple folks in their local coverage determination answer the questions appropriately. The reason behind it is the folks in these meetings, they are not cardiologists or radiologists. For the majority, they are non-practicing in the field of imaging. So you want to break it down and simplify it as much as possible. And that's when it comes to the slide set. You want to have about 5 to 6 slides that truly break it down to the basics, as if you're giving it to a medical student, just simply because the knowledge varies among those who are in the panel. And once you have these three components, invariably, you are going to have favorable coverage determination. This is a simplified version for Plaque coverage, where we met with one of the MACs for local coverage determination, and we did the simplified one slide with graphics that highlights, well, who doesn't need the technology, who needs the technology, and what percentage of patients we anticipate it applies to, and in what population. It's visual aid, it helps, it solidified the concept. Anyone that was not familiar with imaging looked at it and it made sense to them, and that helped us get favorable coverage. So let's say now you have coverage, you get paid for your T code. We've been using T code for a while. So how do we get to Category 1? That's always our ultimate goal. There are two components that we need to accomplish. One is widespread utilization of the technology, and second is publications with at least 5 either randomized clinical trials or large meta-analyses, and preferably guidelines if possible. Number 2 is easy to accomplish. Number 1 is hard, just simply because depending on the prevalence of disease, the widespread utilization is a moving target. If you're talking about pediatrics and congenital heart disease, that number could be in the hundreds. If you're talking about coronary artery disease, that number suddenly jumps to the tens of thousands to be able to say there's widespread utilization. But once it's done, majority of the time, the societies will monitor this, and once we hit that mark, the societies will sponsor the application that will take it into Category 1. For example, when the time comes for a plaque analysis, the society will sponsor the application to go in as a Category 1. And we'll write the language to be vendor neutral as much as possible, because you don't want to keep going back to create different languages that supports a newer technology as it comes along. You want to do the work once. We collaborate with other societies. We don't live in vacuum. Our work affects, ACR, ACC, and other societies. So anytime that we go for a Category 1, we collaborate with all of them and ensure consensus, because that will ensure that the Category 1 go through smoothly during the meeting. We submit the application and discuss an open session with the AMA staff, and the payers are actually on the panel, so they will ask appropriate questions, and we need to be prepared to answer and support the application. And if approved and not tabled, majority of the time, if we go through all these steps that I mentioned, it gets approved. We're not done yet. With just the fact that we got a Category 1 does not mean we're automatically going to get reimbursed for it. So there's usually a gap about a year between when it's approved and when it's released. And that gives us time, or the AMA panel time, to work through a different committee in the AMA called the RUC panel. And that RUC panel is charged with identifying the work value that goes, RVU value that goes with the technical component and the professional component. The technical component is based on data collected from different sites that use the technology. So for the RUC, this is an easy portion. It's the professional component that's a little bit difficult. And here's the part that's always interesting. The professional component is based on surveys. The AMA will send surveys to imagers across the United States, and these imagers will give that survey. And based on that survey, the RUC panel would recommend RVU value to the professional component. They'll give you a range of modalities and will ask you to compare the workload that associates with this technology with other modalities. Here's the problem. Majority of folks are not educated on what that means. And because they're not educated on what that means, majority of the time, they tend to underestimate the work that they do. They always remember the simple cases, or they assume the survey is about how amazing they are. So they always end up underestimating their workload, and hurts their assigned RVU when it comes for the professional component. So we ask folks when we educate them through these educational sessions, we don't want you to overestimate, we don't want you to underestimate. We just want you to think of your common cases, the ones that truly you day in, day out do, to truly reflect the amount of work that you do. Once the survey is done, that survey data is collated and is shared with CMS for reimbursement. AMA RUC committee advises CMS. CMS still makes the final decision. There's hardly a discordance between both. Majority of the time, CMS will go with the RUC committee evaluation, and then based off of that, will assign RVUs, which later is adopted by other payers. So as you can see, every step of the way is managed by the American Medical Association and our own peers. However, we're not educated on the process to be active members and be involved in the process to ensure that we're accounted for. And that's one piece of the equation that I think we can do better. And hustle, rinse, and repeat. Now, this is the same process over and over and over again for every new technology that comes along. This is how we go from new technology all the way to able to function and get reimbursed through the process. Before closing, I just wanted to cover a couple of things, a couple of terminologies in case you hear about them so you understand. So these are the Category 1s. We get paid off of 2 schedules. by Medicare. One is called the Medicare Physician Fee Schedule. And this is the schedule that assigns professional fees to the providers. So when you look every November, they publish it, you look at it, and it has assignment of RVUs to the workload that you do. But it also covers technical components in the office environment, not in a facility owned by the hospital. In the office, that equation is a little bit complex. I just highlighted how long it is. That equation assigns for physician work-related value units, work RVUs, practice expense, professional liability. They calculate all of this, then it gets multiplied by a conversion factor. For 2023, it was $33. And then boom, you get Medicare payment based off of that equation. Almost invariably, the payment under the Medicare Physician Fee Schedule is very low, and it does affect operations when done, and technical component is done that way. Versus when we're dealing with hospital-owned practices or imaging centers, they do fall under a different system. They fall under the outpatient prospective payment system. And you'll hear us say the word APC, or ambulatory payment classification. So this is when the technical component is paid for through an APC. And this is when I highlighted earlier that cardiac CT is hurt because it falls under the APC as all CTs. And by virtue of that, it excludes all the work that goes into it that is otherwise accounted for through stress testing. So that's one of the work that the society is working on, is ways that we can move cardiac CT into a favorable APC that does help us account for the work that's done in it. But that's the difference with hospital payment system. The conversion factor is higher at $85 versus $33 for the physician fee schedule. But the weighing factor for the APC is affected by which category you fall into, and then the charge master. So the charge master is that list of cost that's generated by the hospital. And most of the time, the folks that generated are not familiar with the cardiac workload. So we always end up being undervalued in the charge master, and eventually over diluted when it gets averaged with everything else. So these are the two payment systems that we get reimbursed off of: the Medicare Physician Fee Schedule and the OPPS. I know it's a lot to squeeze in a very short period of time, but hopefully it was informative and it helped you understand what is the difference between policies and reimbursement and coverage, how do we get the codes, the two schedules that we get paid off of, and how can we influence the generation of these codes. So thank you for having me.
Wow, thanks so much, Ahmad. That is, to be able to boil down what is a very complicated topic, and I think confusing for people like me and probably many of our listeners, into to make it that simple and understandable is tremendously helpful. So thank you, Ahmad, and honestly, thank you for all of your work on behalf of all of us on this call. I can tell you, I've always been amazed at the tireless work that Ahmad puts in to advocate for his patients. At the end of the day, it's advocating for patients to have access to high quality cardiac CT services. And so we've got a few minutes for questions, and then we have one question in the Q&A box. I want to encourage all of our current attendees to put in your questions. Is there advocacy for improving the MPFS rate?
So the conversion ratio, the conversion factor, is set by Medicare every year to maintain budget neutrality, and there's work in Congress to try to affect that, because we're the only profession in the United States that doesn't account for inflation, and we always have reduction in the conversion ratio that doesn't account for inflation. But as of now, budget neutrality, i.e., we get the same budget every year and we got to figure out how to split it among all specialties, does affect that conversion factor, and it drops it every year. If we're talking about, is there work that's being done to improve the reimbursement piece for CTA under Medicare Physician Fee Schedule, the society has been working on multiple fronts in the last 2 years. One is congressional work and congressional letter to Medicare to improve the reimbursement. Another one is moving a CT to a different APC or under a different umbrella in the same APC that will improve the payment. And third, we're working on potentially rewriting the Category 1 codes because they have not been modified since inception. And as time goes on, they don't reflect the complexity of cardiac CT and what is involved in it, whether it's the structural world, congenital world, EP planning and occluder devices, so on and so forth, that we're working on a new set of codes that would reflect that and that would help in the estimation and evaluation of work on the Medicare physician fee schedule. So it's a multi-pronged response, but unfortunately, that's how it is in advocacy. It's not one topic that helps you get there. It's multiple avenues that you have to take to ensure better advocacy and better work, better reimbursement for the modality.
Yeah, again, I'll just point our listeners to a really, I think, important article, and both Brian and Mark, I think, were co-authors on this. And this was published when I was the editor-in-chief of the JCCT, and that is the title, "The Direct Cost of Coronary CT Angiography Compared to Contrast-Enhanced Thoracic CT." And the take-home that really struck me is that, as many of our practitioners and listeners know, is that coronary CTA took over 3 times longer to perform. The direct costs were over three times more so than standard CT. And there are a number of other differences, and yet it is kind of lumped in with just standard CT scanning. It was very, very humbling to see the difference in reimbursement between coronary CT, given being the only non-invasive test given a class 1 level of evidence A in patients with chest pain, as compared to stress echocardiography and nuclear stress imaging. So I really advise our readers to take a look at it. And thank you for all of the work that you're doing to try to level set that. I have one question about Plaque. We've seen, and you showed this national coverage decision by CMS for Plaque, and there is a Category 3 code. Give us your perspective on what will happen next, as that, where are we now? Are there any local coverage determinations for Plaque, and what is your perspective on the time and evidence it would take to see that transition to a Category 1 code?
So we are in that step that I highlighted earlier, where we have a Category 3 code and we're actively involved in getting local coverage determination by the MACs and payers. We had a recent meeting, and some of the slides that I shared is just an example of that meeting, where we met with one of the MACs. A MAC is just a regional administrator for Medicare. That covers different regions. So for the Pacific Northwest, for example, is Noridian. So we had a meeting and we went through the evidence. We gave them a thumb drive. We gave them the slide sets that you saw. We answered all the questions that they had, and we had a meeting for about an hour and a half. We answered all their questions, and it was favorable. And we're still waiting for the final determination, but we know from the communications we had with them, it's favorable. So what happens in a situation like this is you got the T code, and your local coverage determination that comes favorable covers the cost as well as a professional component. The tricky part that's going to happen is, and it's very good idea for people to pay attention to that piece. Because it's a T code, majority of hospitals and systems that you work in, they don't have built-in mechanism to pay you for your work. So right after you get the T code coverage, you have to go in and meet with whoever builds the payment system for your hospital or your practice, and grab that piece of payment and link it to RVU within the system, so your work is accounted for and is tracked. Because hospitals and big payment system, they do tend to use what we call the global code. So what that means is, as I mentioned earlier, in a Category 1, we have a technical component, we have a professional component, but you can bill for both under something called the global code. And the hospitals favor doing that because it's less headache and you don't have to track a lot. But what that means is, on the back end, we're not tracking your workload and you're not getting reimbursed for that workload. So you have to make sure on the back end you meet with the administrator in your system and you ensure that that breakdown is assigned so you can get paid for it. That is said, we do have favorable utility of Plaque. There is data on utility. We're getting close towards potentially Category 1 in the next year or two. And the reason that I say the word close is yes, we might have the numbers to say we have widespread utilization. But if we don't have enough users nationwide, when the survey is done, the RUC survey that I mentioned is done and sent out, if the people that get it are not familiar with the survey, they might not do it, or if they do it, they might significantly undervalue the work, and that will hurt our providers when the time comes for them to use the technology. So sometimes you'll see that we will push for them to extensively use the T code because that would help us significantly value their work down the road. I don't know if that answers the question.
Yeah, no, I think it really does, and it's exciting to see this field evolve. Well, I think for the sake of time, we're going to move on to our next speaker. I'm very pleased to kind of transition from the finances to the clinical side. And the question that Dr. Rabat will be addressing is when to utilize some of these advanced analysis techniques, such as quantitative coronary plaque analysis and FFRct in guiding patient care. We'll turn it over to you, Mark.
Thank you so much, Todd. Let me share my screen. Can you see my screen all right?
Yep.
Perfect. So thank you for the invitation. I was tasked with the topic, when to utilize FFRct and quantitative coronary plaque analysis in guiding patient care. So I'd like to start by discussing the PRECISE trial. PRECISE is the first global prospective randomized controlled trial comparing the diagnostic and treatment pathways for stable chest pain. And it really confirmed the CT first strategy and FFRct when indicated, which is in support with the ACC and AHA chest pain guidelines. So PRECISE enrolled over 2,100 patients. 1,046 underwent traditional testing, 1,057 underwent the precision pathway. So of the traditional testing patients, the testing strategy was at the discretion of the site clinician, so whether it be a functional stress test or direct to cath, and all subsequent care and testing was made by the site clinician, and guideline-directed medical management was recommended for all. Now, for the 1,057 participants who underwent the precision pathway, if they were deemed low risk, as assigned by the PROMIS risk score, they deferred testing altogether, which is quite unique to this clinical trial. And if they were intermediate or high risk, they underwent a CCTA. And if the CCTA was positive and FFRct was indicated, then they underwent FFRct. And again, all subsequent care and testing was made by the site clinician, and guideline-directed medical therapy was recommended for all. And the primary composite endpoint at 1 year was MACE, which included death, non-fatal myocardial infarction, and cath without obstructive coronary artery disease. Now, this data was presented as a late-breaking clinical trial at the American Heart Association meeting and was recently published in JAMA Cardiology. And these are the results. You can see that the precision pathway was indeed superior to traditional testing at 1 year, and there was no difference in safety, but a significant improvement in overall efficacy at 1 year follow-up. So how does a CCTA first and FFRct when indicated pathway impact the cath lab? So here's just a case example of an intermediate lesion in the LAD in the upper left image with the red arrow based off of the CT alone. Wasn't sure if this was flow limiting or not. This patient underwent FFRct, and you can see the large delta gradient across that lesion, rendering that specific lesion hemodynamically significant and would warrant revascularization. In the bottom left image, this is the invasive coronary angiogram that corroborated the CT angiogram findings, and in the bottom right is a post-PCI result with a resolution of the patient's symptoms. Now, going back to the PRECISE trial, let's follow 100 patients over their care journey through the cath lab, comparing the traditional testing pathway to the precision pathway. So let's start with 100 patients in traditional testing, 18 of whom would undergo an invasive coronary angiogram, and only 4 of the 18 patients would undergo revascularization with a stent, and 2 patients undergo bypass surgery. So you can see the low diagnostic yield with traditional pathways, whereby 12 patients in traditional testing would have been found to have no obstructive disease and would not have undergone revascularization with an invasive procedure. Now, in the precision pathway, let's take a similar 100 patients, 14 of whom would have undergone an invasive coronary angiogram. So four less invasive coronary angiograms, but you can see that 10 of those patients, so 10 of the 14 would undergo appropriate revascularization, and only 4 of those patients would have been found to have no obstructive disease and would not have received revascularization. So you can see that there's a 78% more likelihood to identify patients in need of appropriate revascularization with the precision pathway compared to traditional testing, and 3 times fewer unnecessary invasive angiograms. And then when you look at how it affects the cath lab value and efficiency with this pathway, you can see that the precision pathway is associated with a positive net impact for the cath lab. So for traditional testing, there is a higher ICA revenue, but you could see that the PCI revenue is significantly lower in traditional testing compared to the precision pathway. So the total cath lab revenue for traditional testing is $104,000 in this 100 patient simulation, and then in the precision pathway, you can see that the total cath lab revenue was $124,000. So essentially, there's a 20% increase in the total cath lab revenue and a 58% increase per cath lab case. Now, we're using the information from CT and FFRct to move beyond its gatekeeping ability to the cath lab and guiding revascularization, but also to assess drug effect. So this is one of my patients that I see in clinic, baseline CT. You can see here, this is the FFRct. All these pins represent lesions of at least 30% stenosis. So this patient had multivessel CAD, significant atherosclerotic plaque burden throughout the entire coronary tree with an intermediate LAD and circ lesion by FFRct. This patient had a very well-controlled LDL cholesterol. His blood pressure was well controlled, his diabetes was well controlled, but he had residual hypertriglyceridemia. So the only change from baseline to follow-up was the addition of icosapent ethyl or Vascepa. And then when I saw him in follow-up, he was interested in taking another look at his coronaries to see if there's been any change over time. And indeed, you could see that there was actual improvement in his intracoronary physiology as assessed by FFRct over time. So I started to see this signal in some of my other patients. So we decided to study this formally using data from the Evaporate trial. And what we were able to demonstrate was all of these patients underwent a baseline 9-month and 18-month CT scan. We performed FFRct on these patients. And compared to placebo, what we were able to demonstrate was that those that received the drug, icosapent ethyl, demonstrated improvement in intracoronary physiology as assessed by FFRct over time. So this is really the first study to assess drug effect using FFRct and really paves the way for future research, especially when assessing drug effect. So one of the major advantages of CT is its ability to move beyond stenosis, look beyond stenosis, and look at plaque morphology, composition, and characteristics. And this is a landmark clinical trial that was published in JACC by Motoyama and colleagues, over 10,000 coronary segments that were studied with 27-month follow-up. And the investigators assessed for 2 adverse plaque characteristics, evidence of positive remodeling and low attenuated plaque. And what they were able to demonstrate was that if a patient had both adverse plaque characteristics, they had a greater than 22% risk of downstream acute coronary syndrome. And what's fascinating is that all of the events occurred in patients in those lesions that were less than 75% diameter stenosis, underscoring again the importance of other plaque characteristics beyond diameter stenosis and reduction. So that brings us to quantitative coronary plaque analysis. So we can identify, we can characterize, we can quantify the burden of atherosclerosis. We can look at total coronary plaque morphology, plaque burden, vessel remodeling, plaque stability, as well as overall risk using QCPA. Now, Coronary plaque volume is critical and a unique determinant of clinical cardiac risk, and in multiple clinical trials now, we've learned that those individuals with larger total plaque volume have a higher incidence of myocardial infarction, higher incidence of cardiac death or acute coronary syndromes, and indeed, it appears to be more prognostic than diameter stenosis alone. Other clinical studies would suggest that after multivariable analyses accounting for sex, accounting for obstructive CAD and other cardiovascular risk factors, total plaque volume, calcified plaque volume, non-calcified plaque volume, and low-attenuated plaque volume all have independent prediction of downstream adverse clinical events. Now, we can also track disease progression and change in plaque volume over time, and patient follow-up with coronary CTA can measure these metrics of plaque progression and potentially changes in plaque type over time in response to medications. So this is data looking at those that received statins compared to no statins, and you can see that those individuals who received statins had less plaque progression over time, which is primarily driven from a reduction in non-calcified plaque progression. Now, this is data that was just presented at TCT from Emerald 2, comparing standard CCTA analysis versus artificial intelligence-enabled quantitative coronary plaque and hemodynamic analysis. In using these various analyses to predict downstream acute coronary syndrome. So for the standard CCTA analysis, which incorporated CAD-RADS and high-risk plaque features, that was the standard CCTA analysis. And for the AI-enabled quantitative coronary plaque and hemodynamic analysis, various metrics of plaque and hemodynamics were assessed. So for plaque features, total plaque volume, non-calcified plaque, low attenuated plaque, burden, and lesion length were all assessed. And for hemodynamics, various metrics of wall shear stress, axial plaque stress, delta, FFRct change across the lesion, and metrics of myocardial blood flow were incorporated. And you can see that there was incremental value of the AI-enabled quantitative coronary plaque and hemodynamic feature analysis in predicting downstream acute coronary syndromes compared to CAD-RADS and high-risk plaque alone. So the AUC was significantly better than the derivation cohort when incorporating these plaque and hemodynamic features. And in the validation cohort, the signal remained. So there was incremental improvement in the area under the curve after incorporating these quantitative coronary plaque and hemodynamic analyses features compared to traditional CCTA analyses. This is some other data that was recently presented a few weeks ago at TCT. This is a sub-study from the advanced registry from our colleagues in Denmark. And you can see that those that had negative FFRCTs and no significant quantitative coronary plaque analysis had very low rates of cardiovascular death or spontaneous myocardial infarction. There was an increase in adverse event rates in those that had significant quantitative coronary plaque analysis, but negative FFRCTs. Those that had a positive FFRCT, but no significant quantitative coronary plaque analysis, had slightly higher rates of adverse events, and those that had both positive FFRCT and significant quantitative coronary plaque analysis had the worst prognosis, with the highest rates of downstream cardiovascular death or spontaneous myocardial infarction. So both hemodynamics and plaque appear to be important in risk prediction. So this is a flow chart of when to consider performing plaque analysis and FFRCT. So if you take patients with a suspected coronary disease, they undergo a CCTA, which is endorsed as a class 1A indication according to the ACC/HA guidelines. You read the CT, you don't identify any plaque or stenosis or CAD-RADS of 0, primary prevention. So once you identify plaque, CAD-RADS 1 through 5, you can consider plaque analysis at that time. And then once you are in that 40 to 90% diameter stenosis range, and this is what's used in the ACC/AHA guidelines as well. You can consider further evaluation with, for example, FFRct. So wouldn't you rather go to the cath lab empowered with all this information? I think one of the next big frontiers in cardiac CT is going to be in plaque analysis, not only in cardiac CT but cardiology in general. We can assess for stenosis, we can assess for adverse hemodynamic characteristics, we can assess for FFRct, we can look at delta gradients across the lesions, which appears to be quite prognostic in prediction of downstream acute coronary syndromes. We can assess the totality or the plaque burden, plaque features, and other novel metrics. For example, assessing the total vascular volume to myocardial mass. So the so-called VM ratio, and this metric may actually shed light into the ischemic potential in those lesions that are quote unquote non-obstructive but may be flow limiting. We also know that there are gender differences and sex differences in this metric. We actually published this data in JACC Imaging a few years ago, demonstrating that males have lower vascular volumes to myocardial mass values compared to women. So smaller changes in diameter stenosis will have a greater impact on intracoronary physiology and FFRct in men compared to women. So I will stop there, and I'm happy to entertain any questions. Thank you for the invitation.
Thank you so much, Mark. That was a tremendous talk. And I think, just for the sake of time, I'm going to make three really quick comments, and we'll hopefully grab some questions at the end. Number one is, it's really exciting to me, having spent, my career, like many of you on this call, not just doing imaging, but translating what we see on cardiac CT, the plaque information, the stenosis information, and all the additional features we're getting from quantitative plaque and FFRct to prevention, is that we now have nearly a dozen drugs that have been shown to reduce hard cardiovascular outcomes. And how do you choose amongst them? And I really believe that plaque is one of the best ways to do so. Some of these are very expensive. We don't want to necessarily apply them ubiquitously. We want to use them in the right patients. And we know the concept that the highest risk patients will be the ones who benefit the most from the more intensive therapies. So that's really exciting. And I think you highlighted the use of not just visual high-risk plaque, but the added value of quantitation. And the second thing is that, and we're going to talk a little bit about CAD-RADS, but I've always been somewhat humbled when we looked at publications at the poor inter-reader variability, if you will, for assessing high-risk plaques. And we know that high-risk plaques, as you show, are very prognostically important, but some of the individual variability in assessing them is maybe not as good, and maybe the software will help us in that way. And then thirdly, you mentioned about, I really believe that CT, both FFRct, plaque, and many of the morphologic features and lesion length and things will revolutionize interventional cardiology, because we're going to see so many more patients going to the cath lab who come with this information. If you're an interventional cardiologist, why wouldn't you utilize that to optimize your intervention, to ensure, optimal stent, planning, interventional planning, debulking, et cetera. So an exciting field for sure. So thank you, Mark. So I want to transition quickly to Dr. Ghoshadra, and we're going to talk about our last topic, and that is one about reporting. How do we report what we see? And he's going to talk to us about structured reporting, CAD-RADS, and then how to incorporate these quantitative plaque analysis and FFRct results into our reports. So take it away, Brian.
Thank you, Todd. Let's start the share. Okay, hopefully you can all see the screen. It's a hard act to follow, both Ahmad and Mark, the really high level that we can do with coronary CT and the things that the nuance that which you guys understand the reimbursement is just amazing. And both of you have done so much work, so thank you for that on the society's behalf. I'm just going to keep it simple. Here's a chest pain case. This is a 56-year-old woman with new onset atypical chest pain. And I'm just going to bring it home how we do things at our hospital. So we always include a non-contrast scan. You can call it a calcium score. If it's a CABG, you may not score it. But what's the likelihood of a significant stenosis with a calcium score of 0? And I'm not going to survey, I don't have that tool here enabled, but if you've read any of the esteemed Dr. Valline's papers, you'll know that it's somewhere between 0.5 and 5%, depending on whether the patient's symptomatic and what the risk profile is. So you don't know for sure, but a calcium score of 0 is not reassuring enough. In fact, this same patient had with her new onset atypical chest pain, had no evidence of CAD by her calcium score, but has non-calcified lipid-rich plaque causing the stenosis in the LAD there. And that was the only vessel with abnormality on these curved planar reformatted images, something we provide on all the cases we do. But really, I like to think of that meme, what's cooler than $1 billion? What's cooler than a calcium score is a non-calcium score. That's what I want to know if it's my coronary arteries. So this case obviously gave us trouble because not only would it have been a false reassurance with a calcium score, which is why we never endorse that for symptomatic patients, we also have a little trouble just eyeballing this and saying whether it's significant or not. And so this is where a very practical adjunct CT-FFR can come in. So basically, with the way you would read this, another survey question for you to answer kind of at home. How would you read it? Well, we've rolled out CAD-RADS 0, even though the calcium score is 0. And I think it's not non-evaluable. I don't think it's a SCAD or anything weird like that, or an embolus. So really this comes to me into the CAD-RADS 3 category. And we use CAD-RADS on every single report. In fact, if I use the old CAD-RADS 1.0, I would know that I couldn't use CAD-RADS in certain scenarios that I can now. I can at least say, hey, non-atherosclerotic issue, say you have a coronary embolus, you would tag that with a CAD-RADS E, saying it's an exception to an atherosclerotic cause of narrowing, or say an anomaly. They come up in 1 to 2% of cases. But regardless, we have here a plaque causing a intermediate stenosis, and that would be called CAD-RADS 3, as that's the worst stenosis, is an intermediate grade stenosis in that coronary tree. We also sent it for a CT-FFR, and this is the response we got from our vendor. Important to note, we do believe in making 2 reports. So first report said CAD-RADS 3. We have an intermediate lipid-rich stenosis in the LAD and the proximal LAD here. If you look at the CT-FFR result, it does come back as positive. So there's positive values just beyond the stenosis. It's a focal translesional gradient. And there's really no other disease that's of note in the coronary tree, just affirming the CT read. So had there been no stenosis, wouldn't have sent it. But in this case, we had exactly the best use case, which is kind of something where we can't figure out. So we make a separate report, second accession number, and here's the impression of that report. So the lesion of concern in the proximal left anterior descending coronary artery at the origin of the first diagonal branch is clearly significant. And then we also give an updated CAD-RADS because now we can add that I+. So your CAD-RADS paradigm gives you the base. Nothing's changed about that. So you have your base CTA, and that's CAD-RADS 3. P1 for the plaque, it's really only in one segment, and then I+ for the potential ischemia based on the FFRct read. So this is a great case to send on for further investigation if you think you can resolve the symptoms or if you think it's going to change management. If it's elective medical management, it's still good to know that there's plaque there and how much of it, but you've kind of solved the case at that point. So our philosophy, how we do it at my site, is we put in a second report and a second accession number. And we believe in 2 things. One, the base CTA and the fundamentals have not changed. So high quality CTA is the basis of any good CT program. And we want the reader to put their chip down because it's possible you might not get the second chip. Not all the vendors are able to process every case. Our non-evaluable rates are about 1%, but still, that's when it goes on for further analysis, it's still, you don't know which one is going to be that 1%. And you, the reader, are still in control, and you are ultimately responsible. We also like the fact that we can close loops. So I'm all for a lot of these adjunctive analyses, and I find that they're nice to have, and sometimes really very important to have. But as Mark's slide showed, I think in one of your slides, 40% of cases have no plaque, no stenosis. You don't really need to expend a lot of resource on those cases. And by the same token, the cases with a lot of complex disease warrant extra resource spend the same way some patients need much more investigation in the cath lab or having ultimately a coronary bypass surgery. So we close the loops as soon as we can. So even if you just have a final result of CAD-RADS 3 and no further information, that's still a useful CTA result. It's much more useful when we can assess the significance of that intermediate grade lesion. And so that's helpful. And it's also nice to have the amount of plaque. Now, this is a pretty simple plaque. It's all lipid rich, but the components of the plaque might be increasingly helpful depending on the situation you find yourself in. Just to prove I'm not blowing smoke, here's the invasive coronary angiography for this case. So they chose to do a DFR here, and it affirmed that it was positive. It's below the threshold of 0.89. Then they put a 4mm drug-eluting stent, and the IVUS was confirmed. So again, a lot of resource spend in the cath lab to make this patient better. Oh, here's the post-stent picture. I'm not an interventional cardiologist, but I'm a very keen observer of the great work being done on those patients that we can select. And everything that's been said is very true. If you can help augment the number of cases that actually need therapy, then it's a win for medicine and your hospital in general. So you know CAD-RADS, but if you don't, here's a nice summary slide. There's actually 5 grades. So CAD-RADS 0, no plaque, no stenosis, do not pass go, do not collect $200, you can go right home. CAD-RADS 1, it's minimal plaque, and you're not going to have any significant stenosis. In fact, it's hard to see that kind of plaque in the cath lab. But it's certainly warrants thinking about a therapy. We've added the plaque modifier, and that can go based on calcium score or the segment involvement score. And right now, a lot of these really detailed adjunctive cases don't yet line up correctly or precisely with the CAD-RADS scoring, depending on which vendor you're using. And then, of course, in this case, we also added a modifier for ischemia, which comes in much later. But a case like this, if it's just plaque in one place, then it might be a segment of 1, or if there's no calcium, then you'd fall over to the segment involvement score. CAD-RADS 2, same story. You're barely going to see anything, maybe some lumps and bumps in the cath lab. None of these cases need admission if they're in your ED, and they're all medical management if they're on the outside. And then rarely you have the extensive higher risk plaque that's still non-obstructive, and that would still be a modifier on your CAD-RADS 2 for the vulnerable plaque or high risk plaque, as we call it on the CAD-RADS 2.0. Now, the other thing is the CAD-RADS 3. That's the one I just showed you. And so that's an intermediate lesion. Even in the cath lab, they like to do an additional evaluation. And so there's a lot of good tools for that now, non-invasively, so we can help select. I'll show you our site data. It's not end all be all, but it affirms what I think you probably suspect, which is it helps us downgrade a significant proportion of lesions by doing that ischemia evaluation with the CT. And then CAD-RADS 4 is clear stenosis. There's a hairline lumen in this case here. And so that's somebody that would, if they're symptomatic, go on and get therapy for sure. Making a reporting macro is not simple. We have a rich text format file, one of our faculty, Anushree Parak, put together, which we made it site-wide throughout our system and we all use. It's nice to have menu choices so you can guide, whether it's a trainee or just myself, just to kind of structure those reports. If you take only one thing away from my much more primitive talk than the much smarter guys before me, just remember, simplicity matters. Making a report that is very simple and easy to understand is good. We're all here spending our lunch hour learning a lot about detailed, or I guess if you're out west like Ahmad, then you're just spending your morning, but you're learning about some high-level CT knowledge. The recipient of your report probably isn't thinking about this stuff in the shower the way that you and I are. And I didn't show you CAD-RADS 5 occlusion or the non-evaluables, and you're gonna have some, but hopefully it's a small amount, and of course the non-atherosclerotic. We were lucky enough during the pandemic to turn on clinical use of CT-FFR from one of the vendors, and we decided to do selective use. Our volume during that year it's tripled now. Actually, we're on pace to do 10,000 native coronary CTs just this year. But of those 3,000 eligible scans during the pandemic, the reader initiated the majority of the sending selectively, and that was about just under 10%. And what you look here is that it's affirmative. So when we did tend to send CAD-RADS 4, the FFR tended to come back positive in at least one vessel. And CAD-RADS 4B, it's 100% of the cases. We rarely would send a CAD-RADS 2 that looked difficult, and usually they were downgrades. But really the sweet spot for that selective use, the way we see it, is to use it in CAD-RADS 3. And this is a hemodynamic significance test. So we're not talking plaque here, but really trying to estimate the potential hemodynamic significance, and nothing's 100%. So many of these go on and get confirmed in the cath lab, but really helping us downgrade the 2/3 of the cases, I think, is where the sweet spot and the value add is. Here's one more case just to kind of complete the thoughts. A male with chest pain, negative ECG in our ED, negative ECG, negative troponins. The calcium score is predictive of CAD. Calcium score helps you not miss calcified plaque, which can happen at low KVs especially. But if you learn one thing, again, calcium score of 0 does not exclude ACS. I won't play this video out all the way for you just due to time, but here's the severe stenosis, which is very clearly a hairline lumen. And the degree of plaque matters a lot here. This is a patient in your ED, so it's not necessarily going to change management today. In fact, today they're probably having RCA ischemia, and it was demonstrated to be true. Stenting was successful. That would be a CAD-RADS 4A, one vessel severe. Nice, simple, right? And in fact, I found once we started using CAD-RADS, our entire hospital talks about CT results just by the CAD-RADS grade. So, hey, your patient with the CAD-RADS 4. It's very simple in setting. Your patient with the lipid-rich, partially calcified plaque causing intermediate grade stenosis. No, that's too much. CAD-RADS 4, it's a simple thing, and there's a matched up treatment. And it's different between outpatients and ED patients or inpatients, but it's still very simple. And so in this case, we would give a plaque score. I think it'd probably be in the P-tier category. How did I arrive at the plaque score? Well, you could do it with calcium score, but you're going to miss all that lipid-rich plaque. You could do segment involvement. That's simple. You can do a third-party vendor analysis. And I hope you don't choose D. I hope you're not feeling it in your gut. You're actually using an objective method. Plaque should be the same no matter who reads the scan and who reads what day the scan is read. And here's a successful stenting of that hairline lumen. Again, this is a case about stenosis more than plaque, but on the outpatient long-term basis, and this patient's going to have a long life to live afterward, luckily, the plaque does matter. If, I had some teaching points, but just no CAD-RADS, clear reports is key. And I think the rest I've already driven home. So I'll stop the share there. Thank you for your attention.
Wow, thank you so much, Brian, and I mean, thank all of you. Thank for all of our attendees. I know we're running a little bit over, but this is just such important stuff. And I mean, if you think about what we've covered today, to go from the finances of CT and all of the work that Ahmad and the SCCT is doing, and I'll just point out, as was put into the chat, the starter kit. If you're at a site that's just starting to do CT and you want to do that, the SCCT has put together a wonderful resource for you to utilize, not only to do high quality clinical work, because that's the foundation of good CT practice, is doing very high quality imaging, but also, as you discussed with your administrators and your local payers, starting at the grassroots level, and all of you on this call have been, all of our speakers were a part of putting that together. I think we have time for just a real quick question, and this is for Brian, but all of you. You mentioned two things. Number one is translesional FFRct. I know there's been some numbers tossed around, advanced registry greater than 0.13. That is in the guidelines, I would add. I mean, is that something that you all are using when you're interpreting CT? And then a second question, and I'll let Brian get first crack at this, is these gray zone FFRCTs, 0.75, 0.77. Does plaque play a role in making a decision about, should I send this person to the cath lab?
Great questions, Todd. And I think we were all learning together, interestingly. So when CT-FFR first came out, you're going to see abnormal values in the distal coronaries when there's lots of plaque. And yes, they are abnormal, but there's not a focal abnormality. For better or worse, right now, the arbiter, the judge of your quality, in fact, we follow every case that ends up in the cath lab. It's still, did they go to the cath lab and find something treatable? And you'd hate to send somebody for some this gradual decline without something to treat. So those translesional gradients matter, and we actually put that verbiage in our second report of that. And there's been some data now to affirm that from registry studies. So I think that's important to know. You're looking for a focal gradient, because if you call something abnormal, not everyone thinks about CT the way we do. We have to be very clear that this patient will or will not benefit or potentially benefit from an invasive angiogram. But the whole point of CT is not sending people that won't need any treatment. So that's number one. And then I think
the gray zone. I mean, I find that clinically that's a challenging. You have an FFRct of 0.77, 0.76. I tend to go back and say, let me look at that lesion. Obviously, integrate that with the severity of the symptoms and other patient factors. And when I see a lesion that's got a lot of high risk plaque, that's longer, it's bulkier, positive remodeling, et cetera, that's going to be someone where I will use that to influence my decision making. I wondered, and obviously, there's a lot to learn as a field. We need more literature in that area, but just to get your all of your input very quickly.
Yeah, so Todd, the great questions, and I'd like to echo what Brian had just said. I'm starting to report the delta gradient of the FFRct across the lesion. In particular, for example, let's say you have a proximal LAD lesion and just proximal to the stenosis, it's a 0.99 in it, and the lesion-specific value may not technically fall into the positive range, maybe 0.82, 1 to 2 centimeters beyond the stenosis. That delta gradient and change across that lesion is quite significant. And there's a lot of contemporary data now to suggest that the delta FFRct is quite prognostic in predicting downstream event rates. So perhaps incorporating plaque metrics, as you had mentioned, such as the totality and burden of disease, the plaque characteristics, et cetera, in that lesion should be revascularized, but we just need more data to support that. But I think it's a very interesting patient and lesion population that we need to further interrogate.
And I'm not gonna lie to you, we've been on the same track as everybody else. It's a learning curve for all of us. We are learning that these are the patients that we're seeing higher events, even from real life practice. And at least if they don't end up crossing the threshold that at this point requires revascularization, we're optimizing their medical therapy a lot more aggressively. And we're looking at the plaque characteristics a lot more detailed than we would otherwise. So it in a way, it's still, like Mark highlighted, in some infancy level, but it is making us change a lot of our practices when we do see it.
Well, I think we're out of time. I would just really want to thank all of our speakers. I'd really put a plug in for Brian's last kind of closing comments that he had there. Take a look at that slide, a lot to learn there. And I would just highlight that the importance of standardized reporting at your institutions. Use CAD-RADS. There's a lot of value there. People will pick up on that terminology. Thank you all again. We were really excited to host this webinar on behalf of Elucid. Thank you.
Yeah.
Thank you.